Good afternoon all. Welcome to our session, Small Pupil Crisis, What to Do. First of all, I thank KSOS and the Scientific Committee for giving us this opportunity. Non-dilating pupil or small pupil demands careful surgical planning, and we have experts from Trivandrum to Kannur to discuss various methods to overcome this issue. Our speakers will be there here in a short while. Now, small pupil means usually pupil less than 6 mm. But this measurement, it's a relative one that depends on the skill of the surgeon. For an expert, even a 5 mm pupil is enough for a safe surgery. But for a beginner, you need a larger dilated pupil. And also it depends on the NS grade. If it's a black cataract, you need a larger pupil. For all of us, even a 5 mm pupil, for a soft cataract, that is safe. And even if pupil is 6 mm, but the iris is floppy, we are going to have trouble. We'll get intraoperative floppy iris syndrome. So we need a larger pupil there. So it's a relative measurement. And the causes of small pupil we usually come across are pseudoexfoliation, posterior sinus K following uveitis, topical miotic therapy, diabetes, and the new villain is tamsulosin. That is an oral alpha blocker. The urologists use this for relaxing the bladder neck smooth muscle, but here we will get intraoperative floppy iris syndrome. Now, when the pupil is small, naturally our rhexis will also become small, and then there will be complication in all further steps. Like when we are doing hydrodissection, there is chance of FPC burst and nucleus drop. And also when we are doing nucleus management in SICS and in phaco. In SICS, there will be difficulty in prolapsing the nucleus from the capsular bag to the AC. And for phaco, there is difficulty in horizontal chop, and there is high chance of injuring the iris and even the rhexis margin. There can be bleeding from iris prolapse, and studies have shown that the risk of posterior capsular rent is 50% higher in small pupil. And next step, during the cortex management, there will be incomplete cortical cleaning. We cannot see what is behind the iris, so there will be incomplete cortical cleaning, which will lead to posterior uveitis and posterior capsular opacification. And regarding the IOL implantation, we don't know where we have implanted the IOL, whether it is in the bag or in the sulcus or half in the bag and half out. So there also problem. And postoperatively also, there is high chance of capsular phimosis and late IOL degeneration. So this small pupil definitely needs careful surgical planning. And I have Dr. Reshmi, an young enthusiastic phaco surgeon, my own student. She will be discussing on non-device options to manage small pupil crisis. Over to you, Dr. Reshmi.